Hello friends, today I will describe about Pheochromocytoma and Paragangliomas. Basically these are neuroendocrine tumors which secrete catecholamines. Okay, and these tumors can be developed either from the sympathetic nervous system or from parasympathetic nervous system. The sympathetic structures that are involved are adrenal gland and sympathetic chain. Whereas parasympathetic structures, examples are carotid body, glomus tympanicus, glomus jugulare and glomus vagae. So these are the parasympathetic structures. So any of these structure can leads to development of paraganglioma, and according to the WHO classification, the paragangliomas that are arising from the adrenal gland is called pheochromocytoma. Okay, and rest of all the structures are called as paragangliomas. Previously, the paraganglioma that is arising from adrenal gland is called pheochromocytoma, and the tumors that are arising from sympathetic chain are called extra-adrenal pheochromocytoma, and parasympathetic structures called paraganglioma. But according to the latest nomenclature and according to the WHO, all the tumors are paragangliomas. Even the adrenal gland is also a type of paraganglioma. It is also called intra-adrenal paraganglioma, whereas all others are extra-adrenal paragangliomas or simply called as paragangliomas. Okay. Coming to the incidence of pheochromocytoma, it is seen in up to 2 to 8% among 1 million population, and it is equally seen in both males and females, and it accounts for about 0.1% of hypertensive patients, and the mean age at diagnosis is 40 years, so it is seen in middle-aged people. And most of the cases are sporadic. However, 25 to 33% of cases can be inherited, and the common genes and syndromes involved with the pheochromocytoma or red proto-oncogene. The mutation of this proto-oncogene leads to either MEN2A or MEN2B syndrome. MEN2A is associated with hyperparathyroidism, medullary carcinoma of thyroid and pheochromocytoma, whereas MEN2B is associated with medullary carcinoma of thyroid, pheochromocytoma, but not with hyperparathyroidism, but instead it will have marfanoid habitus and mucosal neuromas. The incidence of pheochromocytoma in MEN2A and MEN2B is about 50%. About 50% of cases with MEN2A and MEN2B develop pheochromocytoma. Okay, and coming to the VHL syndrome, VHL, nothing but von Hippel-Lindau syndrome, can also contribute to development of pheochromocytoma, and the other associated features should be looked out in patients with the pheochromocytoma, whether the patient is having VHL. Okay, so what are those features? The patient can have retinal and cerebellar hemangioblastomas. They can also be seen in the brainstem as well as in the spinal cord. And other thing is clear cell renal carcinoma, pancreatic neuroendocrine tumors like insulinoma, gastrinoma, Okay, endolymphatic sac tumors of the inner ear, cystadenoma of epidermis in case of males and broad ligament in case of females, multiple pancreatic and renal cyst. It is very important. Multiple pancreatic and renal cyst is a common feature seen in VHL syndrome. And the incidence of pheochromocytoma in VHL is about 20 to 30%. So 20 to 30% of VHL patients are prone to develop pheochromocytoma, whereas the other syndrome which is associated with neurofibromatous type 1 is associated with only 1% of pheochromocytoma. So we all know that type 1 neurofibromatous also have multiple neurofibromas, capillate spots, leash nodules, axillary or inguinal freckling of the skin. Okay, and the other genes that are involved in the mutations that can lead to familial pheochromocytoma and paraganglioma syndrome is SDH A, B, C and D. What is SDH? SDH is succinate dehydrogenase, which is a important enzyme involved in Krebs cycle, right? And they have A, B, C, D subunits. So a mutation of either A, B, C, D can induce various malignancies, including the pheochromocytomas and paragangliomas. Okay, and the other genes which can also cause hereditary adrenal tumors are TM-EM127 and MAX gene. These are the various hereditary syndromes that can be associated with the incidence of pheochromocytoma. And when a patient is diagnosed to have pheochromocytoma, then we need to look out for the clinical features suggesting any of these syndromes. Coming to the clinical features of pheochromocytoma, it is the clinical features are very variable. So hence it is also called the great masquerader. And there are characteristic pheochromospells which occurs in paroxysms, which involves episodic headache, palpitations, and sweating. These three constitute the classic triad of pheochromocytoma, but in the presence of hypertension, it points towards the diagnosis of pheochromocytoma. Remember, the classic triad involves only headache, intermittent or paroxysmal headache, intermittent or paroxysmal palpitations, and intermittent sweatings. So the interval or the paroxysmal generally lasts less than 1 hour. Each paroxysm lasts less than 1 hour and may be precipitated by, what are the precipitating factors? Precipitating factors are surgery, positional change, exercises, pregnancy, urination, especially in case of bladder pheochromocytoma. Okay, when it occurs in urinary bladder, and also various medications. What are the drugs that can lead to this precipitation? Tricyclic antidepressants, opiates, and metoclopramide. So these are the various triggering factors that can induce the release of catecholamines suddenly into these patients, and they can cause episodic headache, palpitation and sweatings in addition to the hypertension, which describes a classic pheochromocytoma spell. Okay, when the patient gives this classic history, there is most likely the diagnosis is pheochromocytoma. So, but In order of frequency, the first most common symptom that a patient can develop is headache, and followed by profuse sweatings. These are the first and second most common symptoms. The other symptoms are palpitations and tachycardia because of release of catecholamines. So pheochromocytoma, all the symptoms are related to increased release of catecholamines, that is adrenaline, noradrenaline and dopamine. So obviously the patient will have hypertension. Usually in coming to the hypertension, the patient can have both paroxysmal hypertension, or some patients will have sustained hypertension. Though paroxysmal is classical, many patients may also have sustained hypertension without any fluctuations. Okay, and these patients will also report anxiety and panic attacks. Okay, and pallor because of some vasoconstriction in the blood vessels of skin, leading to pallor, nausea, abdominal pain, weakness, generalized weakness, weight loss because of increased metabolism, increased calorie utilization leading to weight loss, paradoxical response to antihypertensives, especially when you give the beta blockers, instead of decrease in hypertension, we can see rise in hypertension because of unopposed alpha action on the blood vessels, leading to severe vasoconstriction, leading to increased blood pressure. So this patient can also have polyuria and polydipsia, constipation because of sympathetic nervous system involvement. If the parasympathetic involvement, it is diarrhea. So if sympathetic, it is constipation. Remember that. Orthostatic hypotension. You may surprised to hear this word, why these patients will develop a hypotension when they are actually having hypertension. See, these patients develop only orthostatic, that means fall in BP more than 20 mm systolic or more than 10 mm fall in diastolic BP after 3 minutes of standing. After 3 minutes of standing from lying down position is called postural hypotension. Why this occurs? Normally, when a person stands, what happens? There is pooling of blood in the legs, lower limbs, and there could be fall in blood pressure. Because of fall in blood pressure, the RAS system is activated and release noradrenaline and adrenaline, which in turn causes vasoconstriction of blood vessels and leads to increased venous return and increased normalization of BP. This is what happens normally. But in pheochromocytoma patients, what happens? When they stand, the BP falls, but the RAS system also gets activated to release noradrenaline and adrenaline. But because these patients have already lot of catecholamines in their body, and already the vasoconstriction is at their maximum. Okay, when suddenly there is pooling of blood in the blood vessels, the action of these catecholamines on these vessels decrease because of tachyphylaxis. What is tachyphylaxis? As these patients are having constant exposure to the endogenous catecholamines, the receptors fails to respond immediately. Okay, as a result, what happens? The patient will continue to have pooling of blood in the legs. As a result, the BP failed to improve. The BP failed to improve and leading to transient hypotension and giddiness to the patient. This is called postural hypotension, and this is how these patients develop postural hypotension even though they have a lot of catecholamines in their body, leading to sustained hypertension. Okay, because of lot of catecholamine releasing into the body, it is harmful to the heart and it can cause dilated cardiomyopathy, which is also called catecholamine induced cardiomyopathy. And these patients are at increased risk of developing ventricular arrhythmias and death. Okay, and there is also increase in the RBC count. This is erythrocytosis. Okay, remember this is also one of the tumor that can cause increased erythrocytosis, that is polycythemia. So what are the other tumors that can cause? Hepatoma and nephroma, that is liver cancer as well as renal cancer as well as uterine fibroids sometimes can cause polycythemia. These are all important points to remember, especially for the exam. And because of increased catecholamines, there is elevated blood sugar. Because the catecholamines is a counter-regulatory hormone, so it acts exactly opposite to that of insulin. Okay, so it will increase in these patients pheochromocytoma, the catecholamine increases the level of glucose in this patient, leading to hyperglycemia. And interestingly, there is also increased incidence of hypercalcemia in these patients. So we need to remember one of the important points: hypercalcemia, hyperglycemia, erythrocytosis, or can also seen in pheochromocytoma. This is all very important MCQs. Okay. So coming to the diagnosis is basically involves biochemical testing as well as imaging testing. Okay, the biochemical testing is to document the secretion of catecholamines in the body from the tumors, and imaging test is to localize the tumor. So both these tests are important for the final diagnosis. So we need to document the catecholamines, right? So what are the catecholamines? Adrenaline, noradrenaline, and dopamine. So before going into further details, let us see how the noradrenaline and adrenaline forms in our body. The process starts with the tyrosine. Okay, this is an amino acid. From the tyrosine, with the help of tyrosine hydroxylase enzyme, the DOPA will form. This DOPA is converted into dopamine in the presence of DOPA carboxylase. Okay, this dopamine is converted into norepinephrine, also called noradrenaline, in the presence of dopamine beta hydroxylase. So this is how the norepinephrine forms, and from this norepinephrine the epinephrine form in the presence of enzyme PNMT, that is phenyl ethanolamine N-methyl transferase. In the presence of PNMT, the norepinephrine is converted into epinephrine. Okay, but this step occurs only in adrenal gland. Hence, the adrenal gland is the only organ or structure in our body that can produce adrenaline. Remaining all other sympathetic nerve endings produce only norepinephrine. Okay, that is where they secrete only norepinephrine. And in fact, even the adrenal gland is a tumor, that is pheochromocytoma, secrete only noradrenaline. Okay, so in the normal adrenal gland, 85% release is adrenaline. But in case of pheochromocytoma or paragangliomas or all these type of tumors, the predominant catecholamine release is norepinephrine only. Remember that. Okay. So what happens to these norepinephrine and epinephrine? Okay, this norepinephrine and this is epinephrine. Okay, this norepinephrine and epinephrine are metabolized in the presence of COMT enzyme, catechol O methyl transferase enzyme, to produce normetanephrine and metanephrine. These are the metabolites. Okay, and these normetanephrine and metanephrine are converted into VMA, which is vinyl mandelic acid. So vinyl mandelic acid is formed from the normetanephrine and metanephrine in the presence of enzyme monoamino oxidase. In addition to that, in the presence of MAO, dihydroxymandelic acid is formed from epinephrine and norepinephrine in the form of MAO enzyme. Okay, and this dihydroxymandelic acid is ultimately converted into VMA in the presence of COMT. So what are the metabolic products here? Normetanephrine, metanephrine and vinyl mandelic acid. These are the three metabolites that can be formed from the metabolism or catabolism of these catecholamines like norepinephrine and epinephrine. Okay, so these are excreted in the urine. These are excreted in urine as well as found in the blood. Okay, so the biochemical testing is mainly focusing on measurement of these metabolites rather than directly measuring the epinephrine, norepinephrine or dopamine levels, because we can measure the catecholamines, but these are highly variable in the blood as well as in the urine. So instead of measuring the catecholamines directly, when we measure the metabolites, these are constantly excreted and present in our blood as well as excreted in the urine at regular intervals. Okay, so there is less chance to miss the diagnosis. So most of the patients are evaluated initially by 24 hours urinary metanephrines, both total and fractionated metanephrines are measured, and also the catecholamines are also measured. Okay, the next investigation is plasma tests, that is blood test, in which we also measure the catecholamine levels as well as free metanephrines. Among the urinary tests, the most sensitive test among the urinary test is fractionated metanephrines. Among the plasma tests, the most sensitive as well as the overall most sensitive about 96% is seen with free metanephrine. So when they ask you question about the most sensitive method to detect pheochromocytoma is measurement of plasma free metanephrines. Okay, this is the most sensitive overall. Coming to the imaging test, to localize the tumor, we need to do contrast enhanced CT scan or MRI scan. So both the contrast CT and contrast MRI are equally sensitive in picking up a pheochromocytoma in a patient. And T2 weighted MRI scan with gadolinium contrast is more sensitive than CT scan in case of extraadrenal pheochromocytoma or paraganglioma. Okay. So other type of scan that we can use, especially the radionuclide scan, if the CT and MRI is failed to detect a tumor, then we should go for radioactive tracer scans like iodine 131 or iodine 123, meta-iodo benzyl gonadine scan, which is also called MIBG scan. It is the most specific imaging test, though less sensitive than CT or MRI. It is the most specific test to detect pheochromocytomas or paraganglioma. Other scans that we can also use are indium 111, that is 111, somatostatin analog, Indian somatostatin analog scintigraphy. In addition to the MIBG scintigraphy, we can also use somatostatin analog scintigraphy to localize the tumor. The other one is 18-fluoro-dopa PET scan, positive emission tomography scan, which is also very sensitive. And ultimately, we can also use FDG PET scan. So all these four type of scans can be used to localize the pheochromocytoma or paragangliomas. Among all these tests, MIBG scan and DOPA PET scan are the most specific tests when compared with CT and MRI, but CT and MRI are most sensitive imaging tests. Okay. So if the patient is found to have metanephrines either in plasma or urine, and if these levels are suggestive of pheochromocytoma and not suggestive. If it is not suggestive, then rule out pheochromocytoma. If they are surely suggestive, then it is surely pheo, and we need to localize the tumor by imaging, right? What imaging we need to do? Either MRI or CT with contrast. Okay, if it is localized, then the treatment is surgical resection, complete surgical resection. If the MRI or CT is failed to localize, then we need to do beta-iodo benzyl gonadine scan, MABG scan. Okay. If this MABG scan localize the tumor, then we can proceed with surgical treatment. So, but if it is failed to localize the tumor, then we need to consider FDG or Doppler PET scan, adrenal, venous sampling to localize whether the adrenal is secreting these catecholamines, or exploratory laparotomy should be done to localize the tumor. But remember, FNAC or biopsy of adrenal gland should never be done. FNAC or biopsy never to be done, because FNAC or biopsy can release lot of circular catecholamines, which in turn leads to increased blood pressure and even ventricular arrhythmias, and can cause death of the patient. Okay. So coming to the pathology, before going to the pathology, you may ask me what if we don't do FNAC or biopsy, then how can we know the pathology of the tumor? So we will get to know about the pathology of tumor only after the definitive surgical resection of the tumor. Okay. Once during the treatment, the mainstay of treatment is definitively removing the tumor, right? So once the tumor is removed, the tumors can be grossly small, very small, with circumscribed margins and confined to the adrenaline, though it can cause pressure on the remaining adrenal gland. And the tumor can be very large with the hemorrhagic masses and cyst formation on microscopic examination, and it may weigh up to several kilograms. Okay, the tumors can grow up to several kilograms, and it also can cause pressure symptoms. On cutting sessions, the small tumors are yellowish tan in color, whereas the large tumors are necrotic, hemorrhagic and cystic components are seen. Whereas staining with dichromates, chromium salts, staining with chromium salts produce dark brown in color. That is the reason these patients have this term pheochromocytoma. Oma is tumor, cyto is cell, chroma is color, pheo is dark color. So the dark color tumor, the dark color cell tumor is nothing but pheochromocytoma. The name pheochromocytoma is derived because of the fact that it can be stained dark brown with the help of chromium salts. Okay, and coming to the microscopy, there are chief cells as well as supporting cells. The chief cells are polygonal to spindle shape, and their supporting cells, which are also called sustentacular cells, compartmentalized into small nest formation by a rich vascular network. This pattern is called known as gel balloon pattern. Okay, this is a very characteristic important finding seen in both pheochromocytoma and paragangliomas. When you do the immunohistochemistry to the pathology samples, the chromaffin cells, also called chief cells, they are positive for chromogranin as well as synaptophysin. These are all also called neuroendocrine cells. So hence these tumors are also called neuroendocrine tumors. Okay, and the sustentacular cells or supporting cells are stained with S100. This is a histopathological examination of pheochromocytoma, which is showing nests of cells with a large amount of cytoplasm. Okay, and this is a bizarre cell which can be seen even when the pheochromocytoma is benign. So to call it, to say the pheochromocytoma is malignant, we need to demonstrate metastasis. If the metastasis is present, then it is malignant. If metastasis is absent, then it is benign. Because even in benign lesions, we can see capsular invasion, vascular invasion, and pleomorphic cells, so abnormal cells. So presence of any of these above doesn't indicate it as a malignant tumor in case of pheochromocytoma. Okay, so the presence of metastasis is the only finding which tells us whether the pheochromocytoma is malignant or benign. Coming to the treatment, the main treatment is surgical resection of the tumor, and during the preoperative period, the BP should be maintained 160 by 90 millimeters of mercury. It should be maintained less than 160 by 90 millimeters. Okay, so for that we need to give alpha blockers to the patient. Normally this adrenaline acts on alpha blockers much more than the beta blockers, leading to vasoconstriction, right? Because alpha 1 receptors are predominantly for vasoconstriction, whereas beta 2 receptors are mainly because of vasodilatation, and this vasoconstriction is much more than the vasodilatation, leading to increased blood pressure. To reverse that, we need to give alpha blockers to reduce the blood pressure. And meanwhile, we can also give oral prazosin as well as intravenous phentolamine in addition to the alpha blocker oral phenoxybenjamin, which is given in the dose of at a dose of 0.5 to 4 milligram per kg body weight. Okay, so it will take some time to exert complete alpha blockade. So meanwhile, we can give oral prazosin and IV phentolamine to reduce the blood pressure. Once we are sure that the patient is having a complete alpha blockade, then we can initiate beta blockers, that is propranolol 10 mg thrice a day or 6th hourly can be given to inhibit the beta receptors to prevent the excess tachycardia. So but remember, we should not start beta blockers before the complete alpha blockade, because if if the beta receptors are inhibited, the alpha blockade increase further. Because of unopposed alpha blockade, the blood pressure increases much more, which is called paradoxical increase of blood pressure with antihypertensive drugs. Okay, so we should not initiate beta blockers before alpha blocker is started to the patient. And we can also use other antihypertensive drugs like calcium channel blockers or angiotensin converting enzyme inhibitors, because they have also been used effectively in many studies. And during intraoperative hypertensive crisis, we need to give nitroprusside intravenously, IV drip, okay, to prevent the hypertensive crisis. But at the same time, these intraoperative patients are also at risk of hypotension. If the patient develops hypotension, we should give IV fluids, okay. Even during the preoperative period, these patients are volume depleted, so hence these patients has to be given liberal salt intake and also adequate hydration. So once tumor is resected, the patient may have mild hypotension, which can be treated with IV fluids. And also once the tumor is resected, the patient can have complete cure. But if the patient is having malignant tumor with metastasis, then the treatment is palliative care, and we can also give iodine 131 meta-iodobenzene gonadin in 100 to 300 millicurie doses over 3 to 6 cycles. Okay, the other option is Haverbuch's regimen of chemotherapy, in which there are 3 drugs. One is dacarbazine, other one is cyclophosphamide, and the third one is vincristine. So each cycle is to be given every 21 days for 3 to 6 cycles, and the palliation is achievable in about 50% of patients, and the prognosis of metastatic Pheochromocytoma or Paragangliomas is variable, with the 5 years survival rate is only 30 to 60%. This is all about Pheochromocytoma. I hope you all enjoyed it. If you like this video, please hit the like button and share this video with your friends. And also, if you have not subscribed yet, please subscribe to our channel. Thank you.